Hello, everyone, and welcome to the U of A Researcher Spotlight Series featuring George Schmölzer. My name is Katie Yakimick-Ferris, the Program Lead of Online Engagement in the Office of Alumni Relations, and I will be your host for today. I'm joining you from Edmonton, Alberta, located within Treaty 6 territory. And I want to start our webinar in a good way by acknowledging the University of Alberta. Its buildings, labs, and research stations are primarily located on the territory of the Nahio, Cree, Niitsitapi, Blackfoot, Métis, Nakota Sioux, Stoney, Dene, Haudenosaunee, Iroquois, Anishinaabe, Ojibwe, and Saulteaux lands that are now known as part of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. As staff members and settlers on this land, we are grateful for the traditional knowledge keepers and elders, and we make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on. Today, we are gathering in a virtual space and have participants joining us from across Canada and elsewhere in the world. I encourage everyone to learn more about the traditional territory you're on, wherever that may be, and reflect on the context and history of the land that you call home. Just a few housekeeping notes before we begin. We will be taking questions throughout the discussion and we'll answer as many of them as possible at the end. You can type your question at any time into the Q&A box, but please keep your questions as general as possible. The session is being recorded and will be shared with you following the event, along with a short survey. Finally, we have enabled closed captioning for this event. To turn this on or off, find the CC icon on your toolbar to make your selection. And now I'd like to introduce our speaker. George Schmölzer is the director of the Center for the Studies of Asphyxia and Resuscitation, or CSAR, at the University of Alberta. He is a clinician scientist and practicing neonatologist with the Northern Alberta Neonatal Program. His research focuses on understanding the physiological changes that occur during the transition from fetal to neonatal life, as well as during infant and pediatric resuscitation. Through this work, he aims to improve both short and long-term outcomes for newborns, infants, and children. Professor Schmölzer attained his MD in Graz, Austria, and trained in pediatrics and neonatology in Austria and Australia. He obtained his PhD at Monash University, Melbourne, Australia, and a Banting postdoctoral fellowship at the U of A. He is currently a professor of pediatrics and an adjunct professor of pharmacology at the U of A. He received the King Charles III Coronation Medal by the Canadian Lung Association for this work to improve lung health in preterm infants, and was nominated by the Heart and Stroke Foundation of Canada for his work on neonatal cardiopulmonary resuscitation. Please join me in welcoming Dr. Schmölzer.
Thank you, Katie. And welcome, everyone. Really excited to be here today to share our work we have done over the last 13 years since I'm first relocated to Edmonton from Australia. Before I start talking about the work we have done and take you on a small journey while this work is so important, I thought I'm gonna talk a little bit about CSAR, which is a little center we, back then with my colleagues, established to give what we do a name, to really help to study everything that's happening at birth. And this is basically something to give back to all these German preterm babies who need help at birth. CSAR is, as Katie already said in the introduction, the research focus from our center is really to understand physiological changes during fetal to neonatal transition, and I will show you a little bit more about this in a little while, and hopefully with a better understanding how this physiology works at birth, we can improve the diagnosis of disease, we can mitigate risk, and therefore improve survival And not only improves survival, it's improving the quality of life for preterm babies, for newborn babies, as well as the family and their communities. We really try to include every aspect of research, from basic and translational research, where we work in laboratories, over to simulation and clinical research, where we try to implement what we have learned in the basic science labs into newborn babies to see if these approaches potentially help to improve outcome. And because we do everything, we are quite unique, not only in Canada, we're quite unique in the world, because there's no other program who encompasses everything. What makes us really special is our amazing research team. Without this amazing research team, we couldn't do anything. Over the years, we have become a neonatal clinical trial center who is leading, not only in Canada, but is leading around the world and trying to improve outcomes for newborn babies. We have done a lot of training and innovation. We have a lot of trainees from around the world coming, visiting us to learn and improve outcomes at their intensive care units. And we try to translate what we do into policy. And these are just a few achievements we have had over the last 10 years or so. And you can see that we were quite successful. A lot of students, a lot of funding, a lot of publications, and we are quite involved in a lot of trials. And you might wonder what all these acronyms stand for, but this is how we classify or how we name trials, because many trials have really, really long names and they're hard to remember. So we come up with acronyms to really help us to remember, this was the study. And it's not just something to remember that we're doing this study. Even in our daily approach in the hospital, when we talk about certain interventions, we would still refer to the name of the trial, or this is the trial, or let's do this procedure according to SAIL or plan. So it's not just something which sticks with us for the duration of any study, it sticks then for the rest of the duration of years or decades, because we're treating patients like this across the world. And I'd like to just highlight all these staff members and students and trainees we have. So here you can see all of our staff members who work effortlessly on a daily basis to improve the outcomes for preterm babies and newborn babies. Here's our current students, and they range from being PhD students or master students to undergraduate students, as well as research volunteers who just volunteer some of their time to help advance our goals to improve outcomes for preterm babies. And the list of alumni we had over the years is quite extensive and stretches from every continent across the world, from Canada, North America, Australia, China, Europe, South America. So they really come from many places from across the world. If you ever want to get in contact with us, here are many different ways you can either follow us or stay in contact with what we do. Why is our work so important? Well, timely to this talk, 2 weeks ago, the latest update of the neonatal resuscitation guidelines was published. What are the neonatal resuscitation guidelines? Well, the neonatal resuscitation guidelines is an international guideline which basically summarizes all the evidence which is out there to guide clinicians around the world what is the best approach to resuscitate a newborn baby at birth which needs help. And that's something which is updated every few years as new evidence is available. And so this is really important. And the work we do influences extremely these guidelines. And you can see that within this document, which is published in several different journals simultaneously, there are a total of 339 references. and 12% of all of these coming from our research team. So this is the largest part of any other center who contributed to this evidence. So we are one of the main drivers of improving these guidelines and pushing the science within this field forward. So a lot of work we have done is recognized internationally in this policy document, how to treat babies or help them treat better. Why is it so important? Because everybody who is on the call, everybody is around the world, everyone is born. And without neonatal resuscitation, many of us would not be around. In fact, every newborn baby who is born, so every one of us, will require simple, basic intervention. We call them the initial steps. And if we would not do the initial steps, then many of us would not be here because we might get cold, we have breathing issues. So this is a really big part of everybody's life. Why is this so important? Well, yes, you're born, but when you're born, you're in this unique situation. You are never again in any other day of your life. When you're born, you were a fetus, and as a fetus, you have certain physiological differences compared to once you're born. You're in the womb, you don't breathe because the placenta is providing you with oxygen because your lungs are liquid filled, so you can't breathe anyway. So the placenta is providing you the oxygen. But the moment you come out, you need to reverse this. You need to absorb all the fluid. You're not spitting it out. You absorb it into your lung, and then you have to transition to independent breathing. The heart is beating differently. And because the heart is also beating in a different way, the heart needs to adapt to be ready to pump the blood in a different way once the baby is born. So the transition to your independent life after birth hangs on two important transitions. There's the respiratory transition, which has the task to clear your air liquid out of the airway. Then you basically can aerate the lung. You onset breathing with that, and that will then facilitate gas exchange. And if you do all this, the cardiovascular transition will follow. It's basically an interdependent sequence. It will close some shunts, which were really important as long as you're in the womb. And then it changes and starts coordinating how the heart is pumping the blood through the body. So this is extremely important that all of this works. And if it doesn't work, a baby's in trouble. And how big in trouble they are, you can see here. The day of birth is your most deadly day in your life. At no other day in your life, you have the highest risk of dying. So that's why it's so important that we find out what is the best way to support babies when they are born. Yes, the babies do that on their own, but there's always a few steps we do to support them, even if the babies come out screaming and crying, which we all hope it is happening. Really fitting to the time, November 17 is World Prematurity Day. It's not only about the term babies, there's also 350,000 babies roughly in Canada, which are born premature. And so for the 350 babies born in Canada, roughly 1 in 10 are born too soon or premature. So there is around 35,000 babies who not only need help at birth, but they also require intensive care medicine for maybe a few days, but some even for several months to up to a year. So this is another very important aspect of the work we do to figure out how can we help them to improve the outcomes and potentially even reduce the time they are in hospital. As I said, November 17, Monday next week, is World Prematurity, where we try to emphasize how important the work is we do to improve the life of premature babies. And I just thought I'd show you, because not everybody might know what a premature baby looks like. Here you can see a extreme premature baby. This baby was only born at 370 grams. So really, really tiny, on the edge of viability, but you can see it has some a measurement tool here on his arm, which is called pulse oximetry, to measure the oxygen. It has a little infusion here going in to give the baby all the nutrition it needs, and a respiratory device stuck to the nose to provide the oxygen and the ventilation the baby's needed. This is just one approach of doing it, and there's many different approaches how we can do this. What is important is that of those 35,000 babies who were born premature, roughly 2,200 are born less than 29 weeks. And these babies are in big trouble when they're born, because up to 40% of them develop a brain bleed, which we call intraventricular hemorrhage. 50% of them roughly develop what we call chronic lung disease or bronchopulmonary dysplasia, which is a disease where the lung has an inflammation, and that can go on for years. And almost 50% will have disabilities by 2 years of age. And many of these outcomes haven't been improved since the 1990s. So we are in dire need to find out new ways of how we do things to reduce these complications for the kids as well as the families. And these are just the big complications. There's many, many more complications which might be a bit more subtle, but there's many more we try to address. Why we struggle when we particularly care for babies who are born less than 29 weeks gestation. Well, what you see here is the lung development, and when a fetus develops, the lung develops continuously with the fetus. It starts around 3 to 7 weeks of gestation, where we call it embryonic stage, and then it's slowly forming. And you can see how it looks on the top on those images. And then as it goes on, it goes into what is called pseudoglandular stage, where the smaller airways, conducting airways are produced, and they grow, and then it goes smaller down into the terminal bronchioles. And once it gets to 17 to 27 week or canicular stage, this is where it starts to form the peripheral alveoli, which you need for gas exchange. And this is exactly the time many premature babies are born. We can go as low as 22 weeks gestation as of now. And if you go back 10 years or so, we might have been at 25 or 24 weeks gestation. So we're pushing the limit of viability lower and lower and lower. And as we push this lower, we still need to find out how can we help them to not only push it down, but also to improve the outcomes. And that's one of the work we do here. Now, all these babies, and you saw it on the video, all these babies born less than 29 weeks gestation will have a premature lung, because it's 2 stages before the lung is actually in the stage when you get delivered at term. So whenever you start helping these babies breathe, because all these babies need breathing support, you introduce a few problems, because you have to provide breathing support, which can be with a breathing tube into the windpipe. It could be, as you saw in the video, that's something we call CPAP. So that's a just continuous positive airway pressure to keep the lung open. And either way, because it's not physiological and not natural, it will introduce a inflammation in the lung. So it starts an inflammation cascade. They all need oxygen as well. Some need more, some need less, but that will also cause some inflammation which starts in the lung. Now, when this inflammation starts in the lung, these inflammatory markers, they don't stay in the lung. They go into your whole body. And unfortunately, they then continue to go to the brain to break down this brain-blood barrier, and then hemorrhages like injury or like a stroke, for example, can occur. So we need to figure out ways to reduce this cascade so that we can, in the end, prevent injury to the brain. Similar, at the same time, when you start ventilating, because you're changing the physiology of how the lung is working, you get hemodynamic instability. So the heart which struggles. And again, if the heart doesn't pump in the right way, it's maybe pumping not enough blood, so you get hypoxic. The body starts to reacting, or you give more oxygen and suddenly there's too much oxygen available, so hyperoxic, or the blood pressure fluctuates. Again, it can cause injury in the brain. So we're really trying to find ways of balancing all these systems so that we can reduce the inflammation as much as possible, keep any instability as minimal as possible, so that we try and prevent any injury to the brain. Now, in general, 10% of all babies at birth need help breathing. And if you go to less than 29 weeks, almost all babies, so 2,200 of these babies, need help breathing. And we need to figure out ways of doing better in monitoring, in how to give oxygen, what breathing support we give, if we need to do the ultimate resuscitation approach of giving chest compression and medication, and training. And I will talk about these things in the next little while, just to highlight a few things we have done or we are working on, so that you understand what is potentially on the horizon and where we are at the moment. Now, on that video, you only saw a sensor on the right hand, which measures oxygen saturation, but often this isn't enough. So often there is many other sensors we put on, and this is just a schematic of all the different ways babies get potentially touched or get measured to understand in particular what the heart rate is, because the heart rate is quite important for us to understand what intervention we have to do, because the heart rate goes down, let's say under 100 or less than 60 beats per minute, because while 60 to 100 beats per minute would be normal in an adult, in term babies or preterm babies, they are somewhere around 120 to 160 beats a minute. So we don't want them less than 100. We don't want them less than 60, because it just shows that the baby is not doing well. So we like to monitor it to figure out ways of knowing that the heart rate is in the normal range. And these are all the technologies that are out there. And all of them, as you can see, either include your hands, where there's always a risk of infection to the baby. All the other ones include leads. Now, leads are sometimes fine, but if you have premature babies, they often have really fragile skin, in particular in the first 2 to 3 days. So putting on a lead on the preterm baby can easily cause a burn underneath as a skin irritation. If it comes loose, it can rip off the skin. So it isn't ideal to have these leads on a preterm baby, but we need to find solutions to monitor that. One approach we have studied, and we are continuously studying it, is using video camera, where if you look at this photo at the left, you see a baby sleeping, and if you look at this image, you don't see much. You just see a baby sleeping and the head moving up and down. Now, with a video program which filters laid over this video, you can actually see the heartbeat. So this change in color is your difference between your systolic and diastolic heartbeat. So you can now measure the heartbeat accurately without ever touching the baby. So this is something which could revolutionize how we monitor babies, because we can just have a video camera within the incubator and we could monitor the baby's heartbeat. It works the same way for breathing. When you add this amplifying, you can see the baby breathing. And with that technology, then you would always know if the baby's breathing, because babies, particularly preterm babies, they stop breathing because the brainstem isn't ready yet to understand that the baby is outside the room, and the brain still thinks the baby's in the room. So that would be an easy way to monitor. And you could extend that for babies going home if parents are ever worried. But at the moment, this is just something we're testing to see if this works. And it works really well, even in our extreme premature babies, where we tried it several times, or many times. And you can see here the heart rate is around 160. The respiratory rate isn't measured, but it's around 50. And there's a little bit of motion because we were just holding an iPhone. You know, nothing fancy, just an iPhone making a recording. You can see that the high peak is here around 160 with some variation because of the movements of the hand. And same here, respiratory rate around 50, again with moving. So comparing this to ECG, it shows quite a good accuracy, because the ECG is the gold standard everybody's using around the world. And you can see that it's on average just off by 0.4 of a heartbeat. And that's certainly not much. It can be off a little bit, but in the end, it seems to be quite accurate. And as this technology evolves, this is a potential swift changeover to eliminating any leads to try to find new ways of monitoring those newborn babies. Let's talk about oxygen. It's one of the most important drugs, or one of those drugs everybody gets if they struggle breathing. It's the most common drug used in preterm babies and newborn babies to help them achieve the oxygen saturation they need. What is important for our preterm babies about the oxygen is that when you're born, your oxygen saturation is around 30 to 40%. Now, if I would measure the oxygen saturation from everyone here on this webinar, it should be anywhere around 95 to 100. It shouldn't be less than 95 unless you were a smoker or have any lung issues, which means you don't get enough oxygen into your lung. So our oxygen saturation is at least 95. I'm pretty sure for most of us, it will be somewhere around 98 to 100 all the time. In the room, it's around 40%. So when you're born, you're around 30 to 40% oxygen saturation. Now, you come out in an environment of 21% oxygen, which is in the air, and then we as the neonatal team will help you to provide breathing support. And now you have a total of 5 minutes to hit 80% oxygen saturation. So that's relatively fast, because it's the 5 minutes is not much time to hit that. So you need to be really quick from a medical perspective to help the baby with enough oxygen that you get to 80%. Because if you don't get to 80%, and you can see that more than half of these babies, if you don't give enough oxygen, they don't get to 80% in 5 minutes, then they have 4 times higher risk to get a bleeding in the brain. They are 3 times more likely to die, or higher risk of dying. And they're 2 times higher disabled or death rates in the first 2 years after they are born. Now, if you would be bradycardic, so you have a heartbeat of less than 100 at 5 minutes, your death would increase by another 5 times. So it is really, really important to get to 80% at 5 minutes. Is it easy? No, it is not. It is extremely challenging. In some babies who come out screaming and breathing well, it's potentially easier to get there. In other babies who are not breathing, who are apneic, and we have to help, it could be more challenging. But and then you could say, well, I just started 100%, so the maximum oxygen. Well, the flip side is that if you start too high, you can also risk other problems, because high oxygen is bad for the baby as well, because they don't have any of these antioxidants we have if we would get oxygen. So yes, we need some amount of oxygen, but we don't know how much. And because we don't know how much, we're studying it. And one of the studies we're doing at the moment is called HILO. And as you can see, this is running across Canada and in Ireland. And over the last 3 years, we have enrolled over 1,000 babies to understand how much babies, to understand if starting higher, in that case 60%, versus lower, 30%, will improve outcomes. And the bottom graph is just to show that we always do trajectories, how we recruit, and that's the blue line, but we are actually recruiting at the rate of the orange line, so we are quite ahead of what we were expecting. So and hopefully by sometime next year, we will be able to have enough babies. We need 1,200, and as of last week, we have 1,052, so we're only 150 babies away. So hopefully by next year we have finished this and then get a better answer to understand, yes, this amount of oxygen is better, or no, it's not better. Then the lower one, let's maybe choose a different oxygen saturation or oxygen concentration. So that's where we're working on. We're also trying the same thing in older kids. And on the top is Chelsea, one of our early career researchers. She just joined, and she got funding from the Neonatal Resuscitation program from the American Academy of Pediatrics to study that in babies who are late preterm, so 32 to 35 and 6 weekers. And you can see there are over 10 million babies around the world in that gestation every year, and we still don't know how much oxygen then you need to start. So if we find out that higher oxygen, in our case, 60% oxygen, will be better than the 30 with many units starting at the moment, we may be able to reduce respiratory support. We may be able to reduce some admissions to the NICU, which will improve bonding, which improve breastfeeding, which reduce costs. So a lot of benefits. So this is something we're just starting to work on, and hopefully in a couple of years, because there's many more babies than the extreme small babies, we will have some answers on that. Let's look at breathing support. Well, if you ever have to help breathing a premature baby, the standard approach is that you put the mask on the baby's mouth and nose so that you cover it. But that goes along with a lot of problems. First of all, the masks don't fit well. They're too big. So you get leakage around the mask. Because you push the mask down, you can easily obstruct the airway. So you always have to watch carefully that this doesn't happen. When you place a mask onto the face of a preterm baby, the preterm babies or term babies, the same as for anybody else, has nerves coming out onto below their skin. We have them too. This is called the trigeminal nerve. This is the 5th brain nerve. It comes out here on your lower jaw. It comes here on your upper jaw, as well as around your eyebrows on both sides of the face. And if you put the mask on this face, you trigger this reflex, very simple, and then the babies can stop breathing. And that's not something we would like. So that's certainly problems we face when we provide positive pressure ventilation. And this is what I mean. So these are the masks available for us from companies. And you can see that this mask fits slightly better, but often this mask is used too. And this is covering the whole face and not really just covering mouth and nose. So now you can imagine if you try to provide ventilation with this mask, that the air goes everywhere and potentially not into the baby's mouth and nose, and therefore into the baby's lung. So we came up with a different approach. We thought, hey, almost everyone who is particularly born premature will have an ultrasound. Some won't have ultrasounds because they might not have recognized that they are pregnant, and or they just get born too quickly that ultrasounds can't be done. Because most babies will have, so most pregnant people will have an ultrasound prior birth. And if you get an ultrasound prior birth, you can actually measure the size of the face, and then you could use a 3D printer to print the face mask. And then you get not only an individual face mask, you get a face mask which fits absolutely correct. You can trigger this trigeminal cardiac reflex much less because you can avoid those trigger points. And because this material can be molded to the face because you're using the contour of the baby when you print it, you will reduce mask leak. So this is something we have studied over the last few years, and it is quite successful to help breathing, help the breathing support better for newborn babies. The second cruel thing we do when we do ventilation is that we use this device, which is called Neopuff. And this is a standard device across the world where you do nothing else than use this blue knob and set a couple of pressures. You set a lower pressure, around 5 or so centimeters of water or millibar. And this is what it's called, provides positive end expiratory pressure. With that, you can keep the lung open. We all do this because we try to close our vocal cords slightly, and this creates PEEP. And then you set a higher pressure, somewhere between 20 and 30, to provide your inflations, your rescue breaths, if you would like to say it that way. And that's relatively cruel because you never measure anything. You don't know what you're doing. So one of our other team members, Brenda Law, she thinks about this in a different way and says, hey, let's try to get the ventilator to do the work for us, because we use a ventilator when the baby is already in the intensive care unit, but we wouldn't put the ventilator into the delivery room at birth. Sounds silly, but that's what we do around the world because this device is much cheaper. So we can use a ventilator, and we have studied that with support from the Women's and Children's Research Institute here at the university, and it works really well. But this device is rather cumbersome, quite expensive. It's up to 50,000 Canadian dollars per ventilator, and not everybody will be able to afford it. So this is this nice little tool out there, which we have sourced from a New Zealand company, which created a prototype, which basically does the same as this ventilator for a fraction of the cost. And we're studying it at the moment, and hopefully in a few years, or in a year or two, we can say, look, this works much better than the T-piece device, because this is too cruel to deliver the right amount of what the baby needs. In particular, because when you use this device, this Neopuff, you can have a 4 times higher rate of intraventricular hemorrhage because of the volume you deliver. Now, if you use this approach, we estimate we can reduce the rate of intraventricular hemorrhage by 30%. So certainly, again, worth trying to improve that. We need to use some form of positive end expiratory pressure, because when you ever provide respiratory support to anyone, even to an adult, and if you don't provide PEEP, your lung might collapse. And this is what we certainly need to prevent. Here you can see right at birth, there's a rabbit pup, not a human, which gets X-rays done continuously, and then they're put together into video. You can see that the whole lung is fluid filled, and you don't provide any PEEP. And without PEEP, you can see that here is air, and it goes up and down. This is the lung liquid. So lung liquid is always retreating back. It's going pushed down and then comes back. It's pushed down and comes back up again. And you can see how slowly it is to aerate the lung. While when you use PEEP, this airway stays open. And with that, you can actually then aerate the lung much, much quicker, much more uniformly as well, which is you want, because you don't just want to aerate one area where it's easier to get the gas in compared to the other. So that's certainly an advantage. And we have shown that if you do this by providing PEEP instead of not providing PEEP, you can reduce death or bronchopulmonary dysplasia. This is a what we call chronic lung disease in our preterm babies. So certainly something we have shown the world over many times. And this is something which is used in many places around the world to help babies and reduce death and BPD. Let's talk about something we have done a lot of work in our laboratories and have started to run clinical trials across the world. And this is something we call Survive. And this is something which is much rarer than what happens in adults. And this is cardiac arrest and chest compression. There's only roughly 2 to 3 million babies around the world who would need chest compression at birth. So sounds a lot, but in general, it's much less than adults, which can happen many, many times a day. If you come to the Royal Alexandra Hospital, you might see 5 to 10 a year. So much less than CPR in adults. But what we routinely do is where we provide 3 chest compressions. So we do 1 and 2 and 3, then we stop. We give 1 inflation or rescue breath, and then we do another 1 and 2 and 3. Our technique, which we came up a bit more than 10 years ago, postulates that we say we're going to give continuous chest compression and just give, we call it sustained inflation. It's nothing else than a high pressure, so high airway pressure, continuously. And this is something we have studied in the laboratory as well as in humans. So here, just to quickly show you, see 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. So you do 3 chest compressions and you stop for 1 inflation. And with this other technique, you just give this continuous distending pressure. The way of giving it is to holding this T-piece occluded, and then you just continuously give chest compression. When we studied this initially in our animal models, we found that the time from where the heart stopped when you start chest compression to the time when the heart starts beating again was reduced by 75% with this new technique. And that is really important because every minute of doing chest compression, your mortality increases by 9%. So every minute I can reduce this, the better it is. Why does it work? Well, there's a couple of reasons why this works really well. One reason is because of our routine approach. We don't get enough pressure. You can see here the white dots on the right side. This is the pressure in the pulmonary artery, and this is the pressure in the artery to the brain. It's not high enough. You don't get enough perfusion going. With this other technique, you get much more perfusion, so you can get more blood into the lung, you can oxygenate more blood, and then you can get more oxygenated blood to the heart and more oxygenated blood to the brain where you need it. So that works well. The second advantage is that the standard approach, with both approaches, when you push down on the chest, air comes out. But with our technique, you get air back in when you release the chest. And so you recruit lung, you get more oxygen in the chest. More oxygen into the lung means more oxygen in the blood. So those 2 reasons, it works well. We have done a couple of studies and it has worked really, really well. In the second study, we just recently finished last year. We were around 10 minutes of chest compression time in our standard approach and only 90 seconds with this new technique. And I was in 4 centers around the world. So it is working really, really well. And now we're working on a next study, which is called Survive 2, funded by CIHR. And you can see it will run every continent across the world. So we're really trying to see with this next study, which hopefully is done in 3 to 4 years, that this technique will then be the new approach for anyone doing neonatal resuscitation. The last point I want to briefly talk is about training, because training is extremely important as well. For everyone who's ever been to a neonatal resuscitation, it is extremely stressful, as any other resuscitations. So when you're stressed, you might be distracted, you start making wrong decisions, so you have deficiencies there. You might start to have an impaired working memory, and then you start deviating from the algorithm. And that's not good. Because when you start doing this, you might make errors. It can lead to poor patient outcomes, and the worst case is there are fatal errors and deaths. How big is this problem? Well, whenever you do any resuscitation, there are 2 skills you need. One skill is your technical skills. This is like how to put the mask on the face, how to provide the mask ventilation, how to provide chest compression, how to put a lead on the baby, how to measure heart rate. So these are your technical skills. And most people are really, really good in them. But there are also non-technical skills, which are like, what decisions do I need to make now? How do I communicate? How does teamwork look like? And this breaks down in 2/3 of all resuscitations, and in 2/3 of deaths, they were caused because those skills broke down. Unfortunately, our current training approaches, they do not focus on these skills. They still focus on those technical skills, how to do chest compressions, how to do mask ventilation. They're quite resource intensive, they're time consuming, because a lot of these trainings, they take 8 hours or so, or 4 hours, depending on the course. And you need specialists who are trained in doing this. So we came up with a simple solution, can be used everywhere around the world. It's called Retain. And we created a board and a digital simulator where you can just log on a computer, for example, and play the algorithm and play the game based on real life scenarios, or you get a board game and play it with your colleagues. Does it work? Well, we've done many studies on it, and it worked really, really well. 95% of healthcare providers who played the game think it's useful and reported it was fun. Even after just one training session, their approach of getting the steps correctly increased by 36%. And even 5 months after the training, the knowledge retention was the same as immediately after the training. So it increased and maintained the same, which is something which is not common for any other form of training. And it can be used in many different ways. And by using this, and this is now used in many places around the world, it can have a massive impact if you think about that 1 million babies die a year, and 66% of them die because we break down in knowledge and communication, which is this program providing to train. And if this works, you can save 200,000-300,000 babies easily every year just because you know how to resuscitate better. And with that, I'm thanking everyone for their attention and looking forward for a lively discussion.
Well, I just want to start by thanking you for sharing your research. It is fascinating and sort of overwhelming on how important this work is And I love that it's been, distilled into something that is so easily consumable as a game for doctors to be able to, build that sort of muscle memory. And could you speak a little bit more about the development process of the game?
Oh, sure. Thanks for that comment, Katie. The game was something we had in mind for many years, and it was always this idea, most residents, when they do their first night on call, that you get a game about everything you might encounter. But that's quite a lot. And so, given that all the work we've done in resuscitation, we said, hey, why not do a game focus on resuscitation first, and then we expand. And so we started off with, we went to a computer science class, and they created some games, and these games were great, but they were limited because they were using this World of Warcraft simulator. So, those figures, they all looked like elves or monsters. And I was like, yeah, it's nice, but, not really working great. So we got a team of educators, designers. They were all from the university. So we had from the education department, from the design department, from computer science departments and neonatology. So we were all sitting together and we were working on a computer game because that was the only thing we were thinking of. And it was really challenging for the programmers to figure out how to do it. Because in a computer world, you do, 1, 2, 3, 4, because that's how the games work. But in real life, you can do 3 before 1 and the baby would be still surviving, because it doesn't matter necessarily the first 2 or 3 steps. They don't need to be done in that order. They can be done in any sequence. And one day the designers came with a board and said, here are all the cards, every action, let's play it so the programmers can understand. And I was like, oh, that's actually a really great idea to play. And so we started developing the board game because they came up with it. So yeah, and now we have it.
I mean, I think that's incredible, having so many cross-faculty people coming together towards this one goal. And I think that's something the university tends to do really well. We do have a question that's come in. Has there been any work or thoughts on developing an AI-driven resuscitation agent that is fed real-time mentoring and video and audio data to guide the clinicians, real-time guidance beyond training?
It's slowly in the works. We submitted a application for tools like this in Australia. It's called Frontiers Grant. So we're working on it, but I think one of the problems we have is, in particular in neonatology, a lot of our data is really grainy. We don't record as much data as like adults do often. So until now we relied on like handwritten notes, and now we're having electronic charting. So once we get electronic charting and like we get all this information, it will be much easier to put that in, but it's something pretty sure coming in the next years. I don't know exactly when, but it's something which will come for sure.
It's coming. Oh, that's
coming.
Yeah.
And it might be also that then the smart glasses, like whatever they're called, from I think Meta or Apple or so, you might wear one and you can, get everything feedback in there, in addition to tell you that, hey, this is what you need to do.
Right. We've got another question come in. Was the new resuscitation method to do continuous chest compressions with breaths on certain intervals? And is the game available to the public?
So the game is available for the public. It can be purchased. It's what's it called? Retain Labs Medical. That's where the game is available. I would just hold off because as I said, in October the new guidelines came out. So the game is updated at the moment. So it might take 2 or 3 months just to get through all these new changes. So, and you don't want a 5-year-old game when then a new one comes out.
Fair. I am putting the link to that website in the chat for you.
Thank you. On certain intervals. Well, it works that way that the chest compression, like in neonatal resuscitation, we do 1 minute and then we reassess the heart rate. So you would do 1 minute of chest compressions, and this sustained inflations, these breaths, they are for 30 seconds. You stop for 1 second, and then you do another 30-second one. So these are the intervals people are doing.
That's great. I'll give 1 more minute for folks if they
Sure.
have any questions right now. But is there anything that you'd like to share that you didn't have a chance to in your presentation about the work that you're doing or the research that's going on?
I would just share that, I'm extremely grateful, first of all, for all the parents who says yes and let their kids participate, because it's, a challenging time often for them. There's a lot of anxiety in these parents, there's a lot of unknowns, particularly when they have premature babies. So extremely thankful for them. And I'm extremely thankful to my team and my students, Yes, I sit here, but as you saw all these people on the slides, they do all the hard work. They do a lot of the work, and I can't thank them enough. Could not do anything without all of that.
That's great to hear. We do have 1 more question we'll take and
Sure.
then we'll wrap up. Is there any insight yet as to whether 30% or 60% O2 is better?
No.
Easy.
Because we can't analyze any data until we're done.
Right.
Because when you ever do a study, you will have blinded analysis where you compare, let's say, A versus B, but it just says A versus B. And in general, there's a data safety monitoring board who sees the data, but no one else sees the data. And only if they say, look, there's danger, or it doesn't make a difference, and they recommend stopping, then you can unmask the data, but otherwise you need to wait. I didn't put it in, but we believe higher oxygen is better because oxygen is the most potent breathing stimulant. So if you give more oxygen, the baby should breathe better, and therefore the saturation should be better, therefore the mortality could be lower, but we will know.
Right. Well, it'll be interesting to see your final results when they do come out. Well, I just want to thank Dr. Schmölzer for being with us today. If you enjoyed this session,